All right, let's tackle a diagnostic puzzle that every single one of us is going to face, probably a lot. Syncope, fainting. This is a huge deal. It's responsible for up to 2% of all visits. And honestly, the path from my patient just passed out to here's exactly why, well, that's one of the most critical journeys you'll navigate as a clinician. So let's start putting those pieces together. And the stakes, they're not just clinical, they're huge economically. We're talking over $4 billion a year in the US alone just for the workup of syncope. Now, that number isn't just a boring statistic. It's a massive signal that being a sharp, efficient diagnostician isn't just good medicine. It's absolutely essential for the entire healthcare system. Now, this right here, this is the secret to solving the syncope puzzle. In this age of advanced imaging and all sorts of labs, our single most powerful diagnostic tool is still the patient's own story. Think about that. Up to 75% of the time, the answer is just waiting there for you in the history. And that's our focus today, mastering the history to become a faster, more accurate clinician. Okay, first things first, let's get our definition straight because this is crucial. Syncope isn't just feeling a little dizzy. We're talking about a complete but temporary loss of consciousness. Because for a moment, there's not enough blood flow to the brain. And the key part, the recovery is fast and total. This definition is our anchor, It's what helps us separate true syncope from mimics like seizures or even strokes. So here's our game plan. We're going to approach this just like you would on the floor or in the ER. We're going to start with the most dangerous possibilities first. We'll dive into the red flags for cardiac causes. Then we'll move on to the much more common types of faints. And finally, we'll piece together a high-value workup and talk about that critical admit or discharge decision. Let's jump right in with the stuff we absolutely cannot afford to miss. Look, while most fainting is benign, some episodes are basically warning shots for life-threatening heart conditions. So our first job, always, is to rule these out. And this chart shows you exactly why we take a worse first approach. Any fainting episode is linked to about a 30% increase in mortality risk. But look what happens when the cause is cardiac. That risk doubles. Doubled. So identifying a cardiac origin isn't just about getting the diagnosis right. It fundamentally changes that patient's prognosis. Okay, here is our first major red flag. If your patient tells you they passed out while running, working out, or even just climbing stairs, your internal alarm bells need to be going off. That suggests the heart just can't ramp up its output to meet the body's demand, and that points to serious problems like aortic stenosis or a dangerous arrhythmia. Here's another one that's really, really concerning. Fainting while you're lying down? That just defies gravity. Benign faints are almost always related to being upright. So passing out while supine is a huge clue that points toward a primary cardiac cause, like an arrhythmia, that doesn't care what position your body is in. You have to ask about the moments right before they passed out. Did they feel sick, warm, sweaty? The absence of that warning, what we call the prodrome, is a huge red flag. A typical benign faint usually gives you a little heads up. A sudden lights-out event with no warning, that points directly toward an abrupt and potentially deadly arrhythmia. And finally, always look beyond the patient and ask about their family. A history of a close relative dying suddenly before the age of 50 is an absolutely critical clue. It can unmask inherited conditions like hypertrophic cardiomyopathy, and finding out this one piece of history can completely change your entire workup. So this table kind of pulls all those historical clues together for us. If you hear about palpitations right before the event, you should be thinking arrhythmia. If they already have a known heart condition, their risk is automatically higher. And here's a really great clinical pearl. Having only 1 or 2 episodes can actually be more concerning than having a bunch of them. Why? Because frequent faints are a classic pattern for the more benign reflex causes. Okay, now that we've covered the really scary stuff, let's shift gears and talk about the bread and butter of syncope. The vast majority of episodes fall into 2 main buckets, neurally mediated and orthostatic. These are way less dangerous, but it's still super important to diagnose them correctly. Let's put the 2 most common culprits side by side. So over on the left, you've got neurally mediated syncope. This is the common faint. It's a reflex. Think about someone fainting at the sight of blood. You're going to hear about specific triggers and a long warning period with nausea and sweating. Then on the right, you have orthostatic syncope, and that's all about gravity. It's that classic head rush when you stand up too fast. And you often see it in older patients who might be dehydrated or on a bunch of meds. Just recognizing these 2 patterns is half the battle. So, what's actually happening during one of these common faints? Well, it's basically a reflex that's gone haywire. The nervous system just slams on the brakes way too hard. Your blood vessels open wide, your heart rate drops, and that 1-2 punch causes a sudden, dramatic drop in blood pressure. For just a few seconds, the brain doesn't get enough blood, and out you go.
Now, here's the really cool part about diagnosing neurally mediated syncope. We can actually empower patients to manage it themselves. That long prodrome we talked about, it's a gift. It's a warning sign. We can teach them these simple physical counter-pressure maneuvers, like crossing their legs and tensing everything up, and by squeezing those muscles, they can raise their blood pressure and literally stop themselves from passing out. It's fantastic. Okay, so we've got our potential causes lined up in our heads. Now, how do we actually prove it? Let's build a systematic, high-value workup that gets us to the right answer without ordering every single test under the sun.
This is it. This is the high-value workup for every single patient who comes in with syncope. Number 1, that meticulous history we've been hammering on. Number 2, a focused physical exam that absolutely must include checking for orthostatic hypotension. And number 3, a 12-lead ECG for everyone, no exceptions. These 3 simple, cheap steps will get you to the right answer or at least point you in the right direction the vast majority of the time. Now, let's talk for a second about what not to do. One of the most common pitfalls is ordering a ton of unnecessary and expensive tests. So let me ask you this. In which syncope patients should we probably avoid getting a brain scan? And here is the clear, evidence-based answer. The American College of Physicians is really firm on this. Unless your patient has a new focal neurologic deficit on their exam, or they suffered a significant head injury from the fall, routine brain imaging is not indicated. Just remember our definition. Syncope is a blood flow problem, not a primary brain event. Sticking to this is a huge part of practicing high-value care. So we've worked through the puzzle and we think we have a diagnosis. Now what? Well, the final and maybe the most critical step, especially in the ER, is figuring out the right disposition. Who can go home safely and who needs to be admitted for a closer look. So the management plan flows directly from the diagnosis we landed on. For the common faint, our job is really about education and reassurance. For orthostatic causes, we're focused on volume, more fluids, more salt, and reviewing their meds. But if the cause is cardiovascular, everything shifts dramatically to something way more urgent, actually fixing the underlying heart problem. So who needs to stay in the hospital? This slide is basically your admission checklist. You'll notice many of these are the same red flags we talked about at the beginning. Any sign of heart involvement, like chest pain, a history of heart disease, an abnormal ECG, or if they're hypotensive or significantly anemic when they show up, these are all very strong reasons for admission and further monitoring. We'll end with a question for you to take with you into your next shift. After going through all of this, what's the one detail from the history? Was it about exertion, the prodrome, their family history? What's the one question that you'll make sure you ask every single time from now on? Because as we've seen today, in the puzzle of syncope, asking the right question is very often the key that unlocks the entire diagnosis.